This afternoon is the opportunity to respond in some ways from the different perspectives of ongoing research here at Berkeley. We've amassed 3 panels of some of our greatest minds, and a couple other people as well. No. Looking at the whole question of global change from a focus of the risks involved and how one deals with those risks, the kind of disease or pathogen type issues that come out of what we've been talking about and how one responds to those. And then very importantly, vulnerabilities, the kinds of issues around vulnerable populations, access rights, et cetera, ensuring that people do not be left behind. So our first panel on risks is chaired by Kirk Smith. As I said this morning, Kirk is really the godfather of this whole process, linking broad multidisciplinary types of global change to global health. His panel, he is the professor of global environmental health and the director of the Global Health and Environmental Program in the School of Public Health. And I'll ask Kirk, if he would, to introduce the rest of the panel.
All right. Thank you. So I'm just going to introduce our panelists quite briefly and ask them each to give a short statement of what how they're thinking about these issues, and then we'll move to questions and responses from the audience. And we have as we heard, a very distinguished group of faculty here. Michael Hanneman is Chancellor's Professor of Agricultural and Resource Economics, and Inez Fung is Professor of Atmospheric Sciences and co-director of the Berkeley Institute of Environment. And Jim Hunt is Lawrence Perino Professor of Civil Environmental Engineering and also co-director of the Water Center. An atmospheric scientist, an engineer, and an economist. It's a very good combination for taking a look at some of these problems, and we're just going to start off with Michael and move from there.
Okay. Well, a couple of disclaimers. First of all, I'm not a scientist, I'm an economist. Secondly, I was raised in England, and England has a long tradition of dealing with different difficult problems by muddling through. It's an art form in England. That's why I am in America. But it may be that at the end of the day, muddling through is the best we can do. And the third disclaimer is George Bernard Shaw referred one time somewhat derisively to doctors who specialize in diseases of the rich. And most of my research on water and on climate change has focused on the United States and Western Europe. Not areas where the most severe problems arise. I want to make a few observations. Steve referred to economism as a religion, and I thought of it more as an ideology, but we needn't quibble. And he objected to people who dollarize, and I spend quite a bit of my time dollarizing the natural environment. But I actually think that's not the issue. That is to say, when the analysis of the costs and benefits of climate change, even for the United States, is looked at seriously, which it hasn't been done, which hasn't happened for the most part yet, it's clear that the existing analysis greatly understates damages, even the ones that are covered. And my own research suggests that even for the United States, a calculus of benefits and cost would imply that it was in our interest to invest the resources in reducing emissions because the impacts would be so large. Economics does have bits of theory that are relevant, but also are troublesome or worrying. And just to put this in context, one talks about change, but the first thing is to look at the baseline, that is, the situation now. And in many cases, that's a mess. And so we're not adequately dealing with the environment, with stresses that we face now, even in the United States, even in the rich countries. There's 2 implications. One is adaptation is sort of win-win. That is, the first step for adaptation in California and in the US is to get our house in order. to do a better job of running the water system, to do a better job of environmental protection, to do a better job of poverty alleviation, to do a better job of dealing with the threats we face now of flooding and other extreme events. So we need to do that even without climate change. But what's worrying about this is the fact that these are things that are in our interest now that we're not doing. And if we can't get around to do things that are in our interest now, why do we think we will become enlightened and do other things that are needed to deal with climate change? And that leads to the second point of 3 points I want to make. The second point is climate change is to a tremendous degree about redistribution. Climate change is not uniform, so different areas will be impacted differently. Also, there'll be different effects at different points of time. But if you think of agriculture, parts of the country that have cold temperatures and can't grow many crops, the northern areas of the US and Canada will benefit. We will have Cabernet Sauvignon grown in Canada. That's good for the Canadian wine industry. That's bad for the California wine industry. And that's just a metaphor. The changes will rearrange things greatly, benefiting some groups, harming other groups. And economics does a bad job, or rather economics avoids thinking of distribution and redistribution. But that is the essence. So for example, if one does an economic analysis, there are some winners as well as losers. The issue is going to be how a governance system, how a society deals with those. There's an old joke about how many psychologists does it take to change a light bulb. And the answer is only one, but the light bulb has to want to change. And with a lot of this, the point is there has to be a will to do this. What is scary about some of the aspects of climate change impacts is that they involve collective action. They require collective action. They involve infrastructure. They require investments, not by individuals, but by groups of individuals. They require collective action. Collective action, and there's a huge body of theory on the difficulty of collective action. Because you don't get a good match necessarily of who pays the cost and who receives the benefits. If you look at the California water system, for 60 years we have failed to reach a decision or an agreement on what should be done in the Delta and what should be done to limit, in whatever manner, diversions. There are two aspects of this. There's no agreement on what should be done, and there's no agreement on who should pay for whatever should be done. Now, climate change, and this is the last point I want to make, adds another complication, which is the risk and uncertainty. Where you're dealing with a change in a probability distribution, there may be no agreement that there is a problem requiring action, as well as no agreement on what the action should be, and as well as no agreement on who should pay for it. And the last thing I want to point out is economics has a well-developed body of theory on risk and decisions under risk. And the key notion that that's associated with that is the notion of risk aversion. People, it's an empirical question whether people are risk averse and how risk averse they are. But the notion of risk aversion is that you will spend money as insurance to protect yourself against the consequences of an event that may not occur. You don't know. So we spend money to insure our house every year, even though we may never have a fire in the house. But it's worth spending some money for the protection, for the peace of mind, for the comfort. And this is a theme Steve has has expressed eloquently for 3 decades now. Climate change is largely about risk. And it's about taking action to protect ourselves against risks. And in this context, I think risk aversion is highly justified. We, in many aspects of government, do a bad job of modeling risk, of thinking about risks. People want certainty, so explicitly dealing with risks is very difficult. But we're all familiar with the notion of insurance, and at the end of the day, many of the actions, both for mitigation and adaptation, should be seen and are justified as forms of insurance.
Thank you.
I want to talk about climate change in terms of severe weather. My area of work is running and analyzing the huge, long climate models, and I spend a lot of time with a color bar trying to figure out, at the end, all the plots go red. Okay, they start sort of neutral, pastel, and then at the end, the temperature map goes red all over. If I plot soil moisture, it goes red all over. Everything goes red all over. So the challenges I have when I think about climate change is not just staring at all the red plots, but the implications of the changes in the probability distribution of severe weather. So right now, I don't need to tell everyone about the fires in Santa Barbara. 18,000 people were removed from their houses. And when I think about that, I also go back to Katrina and about the relocation of the people and how they were relocated, the health situations, and whether, even if we could predict, this is a sure thing with Katrina, we knew it was coming with the fires, those are all predictable events, we have warning. What are the health implications, the freshwater implications of the people who are relocated, the mental health situation of all the people who are relocated, the loss of place for the people who cannot go home, the loss of possessions and loss of lot of photographs and personal memories there. So that's an aspect I look at every time I look at my red plots of floods, of fire, of hurricanes, of severe weather. The 2003, the heat waves of Europe, 30 or 40,000 people died. But then one is also, and so are we prepared for that kind of heat waves, which will be much more, which will be the norm in 30 or 50 years' time. So, but I keep coming back to the book that I think Michael and I both read about the heat wave in Chicago. And the question there, and one of the questions raised that was very interesting to me was the death toll from that heat wave was lower than what the worst nightmare. And so when one looked at that, it was very interesting to read the book and say, well, the people in the developments were not using their air conditioners because they could not afford the electricity bill, but they did take public transit to the grocery stores, which had backup power, and they could sit by the freezers. So that was one way that Chicago survived the heat wave. So as I think about as I look at all my red plots, I think about how prepared we are. I'm not going to talk about low probability. This is high probability that we will have heat waves, we will have extended droughts, we will have severe storms, we will have floods, and all the things that we know we have experienced even in the last 5 years. So the challenge, I think, is how do we handle them in terms of public health, and are we prepared to do that?
Hold the mic a little closer to your mouth.
Okay. I'm the engineer, and it's good to follow an economist and a scientist. Engineers solve problems. We don't identify problems very well. We look to this group and others to tell us what the problems are that need to be solved, and we work with many to solve them. At least we try to solve them. In terms of risk management for environmental health, we know how to treat water. We know how to treat wastewater. We know how to improve air quality. We know how to improve food safety. Implementing these things are another issue. If you want us to build a 100-story building, we can do that. We would probably surround it by a surface parking lot, though. That isn't the optimal solution. So you want engineers to solve problems you've defined. You don't necessarily want them to define the problem for you. So technology is not a limitation in what we're facing here on global change and global health. The technology's there. It's how do you utilize it? One example I've heard, there's a book out on, does the world need 1 billion Priuses or nanos coming from India? I view those as sort of fax machines, a temporary solution to a problem. Is it a long-term solution? I don't think anybody would admit it is. The other thing that I've learned recently is that there are 3 billion cell phones in this world. More than there are toothbrushes, I am told. So we, as individuals of this earth, we in communities, we in governmental bodies and industries have made decisions on what technologies we want and how we're going to utilize them. And we voted with our feet, our money, our interests. I'm always familiar with pictures of developing countries, and Cuba comes to mind when you find cars on the street. How old are these cars? Basically, when the embargo stopped is when they stopped bringing in US cars, but they're running. Why? Because it's important to them. They know how to make cars run. They know the technology. They will make it work because this is what they want. So as an engineer, I'm looking for problem definitions, and we can work on solutions. And I think there's a real untapped resource in this campus and in this audience, and that has to do with the students. In the environmental engineering graduate program, where I read applications to go to graduate school, for the last 3 to 4 years, 50% of the students want to participate actively in solving environmental health problems within the United States, but largely externally. And they've had experiences where they've spent a week, a month, a summer in a developed, less developed country, either looking at water supply systems through Engineers Without Borders and these other groups. And they're motivated. And the question is, when they come back to graduate school, are we satisfying the need of these students to participate in these solutions with our traditional structured programs? And I'm not sure we are. And I've defined this somewhat cynically as defining the post-Peace Corps experience. What is it the students really need to be able to work and solve problems that we all need to be solved? And it isn't a technological solution. It isn't a microbiological solution. It's finding the integration to actually solve a really complex problem. Thank you.
Okay, thank you. So, let's open it up to the audience. Questions? Complaints?
Yeah. In looking through all the talks this morning, Trevor's talk and the panel. Speak really loud. In listening to the talks this morning and what the panel has said, there's kind of a common theme emerging for me, and that's what I would call sociological inertia. We seem to have certainly many, many tools to solve the problems to a particular point. Obviously, new tools are going to be important to do things better perhaps than we can do them, but there are many things we can do now. And one of the things that Trevor said this morning that really struck me was that all these doomsday scenarios were spun out during the 60s, and yet it's taken us 40 years to come to the point to say, yeah, there was really something to that. Many of us knew it, but not nearly enough, and for some, we hadn't got the message out to, I guess, our socio-political systems to have the willingness to do these things. We might know they exist, but we actually aren't willing to do what it takes to implement these solutions. So to me, it's a very interesting problem, and perhaps when we talk about what can Berkeley do, we can really brainstorm this issue of how to narrow this sociological inertia gap so that we can do things at a better pace, and whether it takes new technologies to help that or not, or whether it's purely in the political or social realm, I think is an interesting question. So maybe the panel could address this to some extent.
Yeah, I enjoyed Alex's talk, and he emphasized that there are proven cost-effective technologies, but they're not used. And there are two sets of reasons. And the point is, this is a common fact. I mean, there are things we know how to do. Sacramento faces a flood risk 3 times greater than the assessed flood risk of New Orleans. So that's known, but no action has been taken 4 years after Katrina. There are two sets of factors. One I've alluded to, the mismatch of costs and benefits. That is, the people who have to pay for action don't reap enough of the benefits to justify it. And that's partly an issue of politics and of governance. It's a matter of finding structures, finding ways, so that it is in the interest of people to take action that a society needs to have taken. And that requires, I mean, a major issue with, for example, water supply in developing countries. I have a paper coming out in the Copenhagen Consensus on why the Millennium Goals aren't being met and are not going to be met. And it's because, for example, for large-scale urban water supply, that technology is immensely capital intensive, more capital intensive than any other technology, than cell phones, than telecommunications, than electricity, than gas. And the problem is, all of the investment has to occur up front. Until you have a complete network, you don't get a drop of water delivered at the end, even though that network will sit around for 150 years. But you can't get the people 150 years from now to pay for it now. And so there are issues of matching costs and benefits, which are difficult. The other, though, has to do with decision-making. I do some work in market research, and David Levine does, and you ask why people don't do things, and there's sort of two sets of reasons. One, the issue may not be salient for them. It's not receiving their attention. And the second thing, though, is once it is salient, issues have attributes, whether it's being able to go at 2 o'clock in the morning, to get medical care, rather than having to travel a great distance at an awkward time. There are many attributes, and essentially, marketing is about designing products that people will want to buy by tweaking the attributes so that you emphasize the attributes that matter to people, and you minimize the ones that turn them off. And with many of these issues, and Alex's talk was a beautiful example, you need to tweak or modify the attributes of these various adaptations. So it is in people's interest. So it's partly making the issue salient, partly designing it or finding ways of designing it that people will be more willing to do it. And it's lastly handling the distribution of costs and benefits so you get an alignment of people's interests so the people who need to take action are motivated to do so.
Anybody else want to comment? Yes? There was a question right here.
It's not exactly a question, it's a comment in response to that question. One of the things that I sometimes say, but I didn't include in my presentation, is that given that litany of bad news that I laid out, if I look globally, I tend to be a pessimist. But when I look locally, I see signs for hope. I'm not necessarily even an optimist, but at least I see signs for hope. And I do think that one of the ways that you do get those socio-political changes is probably not by going to the federal government or the state government, but by going to local government. And if you look at who's led on, in terms of governments on things like climate change or tobacco control, for that matter, or a whole bunch of other things, it's been local governments that have led. And so that's why I think the focus of your work here on understanding global change, but looking at urban responses, is really important. That's really where we have to go. And there's lots of folks working on that from the International Council on Local Environmental Initiatives and the Healthy Cities Project and all the rest of it. So there's actually almost a global infrastructure to work on with that. But it is at the city level where there's hope. I'm not sure I see a lot of hope in national governments and therefore not in international bodies either.
Two weeks ago, I attended a discussion at the Museum of Art here on creativity in the times of climate change. And a very important lesson there about the role of art in climate change is that people won't act unless they feel that there's a need to act. So it's not a theoretical problem, and it's not my presenting them a whole pile of equations. It's not going to motivate anyone to act. And so what I was really excited about was a project here there's a Professor Niemeyer in engineering and art, and he has developed sensors, cute, not little boxy things, but little cute little sensors that he had put in the inner schools of LA. And he put them in schools, didn't tell the students, so the project is the students were not allowed to text during school time, and so this is a project where you only text. Okay, so the students were very excited, and they went and they had to find the sensors, and then they had to go figure out what they do because there were no instructions. So the sensors measured light, temperature, CO2, volatile organic carbon, and noise. So that they have to run around and discover what raises the CO2 level, what raises the volatile carbon, etc. And so then by doing that, they started texting poetry. It was a fantastic thing and I totally, your comment about acting at the local level is trying to find ways to communicate or to get people to feel. It's not just my standing there in class and doing my lecture, but getting the engagement and the buy-in, and there are many creative ways that have been devised to deal with it. So the students are actually going around and trying to figure out where the pollution is and where the CO2, where the volatile carbon is coming from, the noise level, and so that you can immediately, because everything is real time, Wi-Fi and everything, you can immediately see the behavior changes on a very local level at a particular school.
Any other comments? I wanted to raise an issue. I mean, this panel is titled Risk, and it follows the discussions this morning. For example, Steve has been making this analogy with insurance, or it's not an analogy, the point about insurance for many years, decades. But one of the odd things about, or it has been about climate change, I mean, people look at the uncertainty of some types of things, for example, dioxin or radiation, and they go to the top of the range of uncertainty to make their judgments. With climate change in the past, people have looked at the range of uncertainty and they go to the bottom of the range of uncertainty. Well, we're not sure, so let's not do anything, as opposed when you look at dioxin or something, we're not sure, so let's do everything to get rid of this stuff. And of course, then, and then you look at fires, people probably have a pretty good idea of the risk of fires. They pay insurance for it, they see it in the news, they spend a lot of experience with it, and they recognize the need to protect themselves against a serious fire. So how do we get the climate change uncertainties and risks, which drive a lot of the actual impacts and our need to do something about them, how do we bring those into a more an insurance framework so that people understand, without waiting till the Greenland ice cap completely melts and it's absolutely driven on top of people?
Well, I'll give the answer I think Steve would give, which is the phenomenon you're describing is distinctive and unique to the United States. It's not true in Europe or else. And it's distinctive to the United States because in the United States there was a very successful marketing campaign, lying campaign, disinformation campaign to emphasize sort of natural variability. Solar cycles and the rest of it. So that conditioned people to think that the peaks were Mother Nature throwing a hissy fit, and there's nothing we could do about Mother Nature, and we certainly shouldn't expect American business to spend money to offset, Mother Nature's tantrums. So I think that was a result of a particular information dissemination campaign that changed how people saw things, and I think that campaign has, in the last few years, has lost its influence, but it's left a legacy. And there's another disinformation dissemination campaign, which is that it would trash the American economy to reduce our emissions. President Bush repeatedly said, trash or destroy. And I just want to say a word about that. Of course, in a way with climate change, the crucial issue is timing. And first of all, on the impacts, it's a matter of timing. We know temperatures are rising, we know sea levels are rising, we know extreme events are becoming more common, and we hope to slow that down. Whether we can slow it down in time to avoid unpleasant outcomes, no one knows for sure. There's differences in the models and so on. And so we're sort of in a race against time on the impact side. But on the mitigation side, it's true. If we had to reduce emissions greatly overnight, that's difficult or very costly. And in economic terms, one simple way to do it is to shut down economic activity, of course, as the American banking industry has helped us to do. But one way you get 20% lower emissions is you cut production, 20% you cut employment, 20% you produce, 20% less, and you have less. But of course, another method is to produce things using different technologies, to produce different formulations of commodities, and to substitute away from fossil fuels, away from high emissions. But that requires change in production methods, maybe change in equipment, change in capital assets. And and the more time you have, other things being equal, the lower the cost of bringing about change. And so it's a race against time. On the one hand, keeping the cost down by making adaptations in sync with the natural investment cycle, but on the other hand, making this change before extreme consequences come along. But the evidence of California, and I will just repeat this for those of you who don't know it, the famous Rosenfeld effect, from the 1950s to the 1970s, electricity use per capita in California grew at the same rate as that in the United States. And then in the mid-70s, they diverged. Electricity use per capita in California stopped growing in the mid-70s when we created the Energy Commission and made other changes. And electricity use per capita in California has stayed the same for the last 35 years. Electricity use per capita in the United States has risen. It's about 50% higher than it was in the 1970s. And electricity use per capita in the Western states is about 2/3 higher. So California is distinctive in making a sharp change in social behavior. But in general, these things take time. But the argument that it will trash the economy is false. But that is still, I think, the mainstream thinking in much of Washington. And so it's this combination of emphasizing the natural causes of the fluctuation that has led to this focus on the bottom of the cycle, the bottom of the graph, not the top.
Yep.
I think to follow on what you just said, the California example is to a large extent the success of the engineers. To give us Energy Star, to energy efficient appliances, so that the behavior change is not that painful. And I think that's a very important lesson there, is to have the problem identified, and for the engineering to be not just the solution be there, but can be implemented at a large scale, so that the pain level to us is not that great.
You want to take credit for this?
I had nothing to do with it. But the time constant you're seeing in this is sort of the 20 to 30 years out to actually do something significant when you're dealing with changing societal behaviors and new technology coming into a system. It's a long-time investment.
Well, see, the amazing thing with California is not that it started diverging in 1975, and it stopped dead in its tracks. In California, it really was a dramatic change. It had been growing, and then literally it flattened out within the space of a few years. Now, that's an unusual event, and I don't think it's been studied adequately, and I think it arises from multiple causes, not just a single agency, a single regulatory agency, and not just a single set of regulations. But there are some things that I think can change quite quickly, but there has to be the will to do this, and that's what we may now have.
We're going to have to close this up, I think, but is that right? But what I get from the California example, I mean, there are many aspects of it, but is the necessity and the huge power of long-term consistent policy. You know, Republican governor, Democratic governor, Republican legislature, Democratic legislature. There were variations, but basically they supported this over a period of 30 years. And the other thing is, it's self-serving, was the use of the university research structure and in the labs too. The Lawrence Berkeley lab had a big part to do with this, but it's so the California does have a system in the state government of taking advantage of university research that helps bring the engineering results in and the economists and the analysis and so forth. There are other factors, but that I think it's a great example of the power of long-term consistent policy. And that in fact may be the biggest, or certainly one of the biggest lessons. But George says, I think we have to move on to our next. So let's give our panelists a...
All right, we're ready to start our second panel. This is more focused on disease, the outcome of dealing or not dealing with some of those risks. The moderator for this panel is Lee Riley. He's a professor of epidemiology and infectious disease and chair of the Division of Infectious Disease and Vaccinology, which is not a religion or a ideology, right? Yes. Yeah, okay. Here at UC Berkeley. And he'll introduce the rest of his panel.
Okay, thank you. So we're going to discuss a topic on diseases. And I think we're originally going to discuss something related to so the spread of drug-resistant infections, but just fortunately, and we actually planned this, there was a swine flu epidemic that started in Mexico about 3 weeks ago. And so we thought this was a very topical example of a disease that we can discuss. So we have a panel here who are all experts in this field, just happens to be experts in this area. So let me introduce them to you. The person sitting next to me is Dr. Reingold, Arthur Reingold, who is the head of epidemiology and biostatistics here at the School of Public Health.
Not biostatistics.
Not biostatistics, he says. He's head of epidemiology. And he is also the Ed Penho Distinguished Professor of Global Health. And he is also, he's a, well, he'll talk about what he does in relationship to the swine flu. And then the person sitting next to him is Eva Harris, that you heard this morning. She is a professor of infectious disease, also at the School of Public Health. And she's also the director of the Center for Global Public Health. And then we also have Tomas Aragon, who is a professor of epidemiology, and he is the director for the Center for Infectious Disease Preparedness. So each of them has his or her own way of dealing with this epidemic, and we thought this would be an interesting topic to cover in relationship to the three themes that we discussed this morning: the issue of globalization, urbanization, and climate change. So, Art Reingold.
I think Tomas.
We're going to do it.
Okay, what I want to do in the few minutes that I have is just to give you a quick overview of the public health response that you're observing. You're getting a skewed view if you're watching the media, but I want to give you an idea of what's going on behind closed doors, what's going on in the conference calls, what people are thinking about. And I went ahead and I made 50 copies, and it's circulating here. There's a one-page sheet here. At the very top, it's just a little bit about our program. I'm not going to go into that. You can read that. But I want to actually just quickly focus you on the second part where it says Pandemic Influenza Public Health Response Plan. And what I have here is just an outline summary of the key things that public health is focusing on. And this is really occurring globally, so it's not just in the United States. And certainly the success of some of this depends on infrastructure and resources. But the first one is surveillance and epidemiology. The second one I have there is laboratory diagnostics. The third one I have here is transmission containment. So one of the challenges with influenza is that when you have a new strain that's introduced into the population and there's little or no immunity, you don't have a vaccine. And then there's the issue of antiviral medication. So in the absence of a vaccine and not having enough antivirals, we have what we call community mitigation measures. And here, just a broad category, you'll hear people talk about case isolation, which is isolating cases. You'll hear people talk about quarantine of exposed. You'll often see the term quarantine misused in the media. Oftentimes they say quarantine when they're talking about cases. That's incorrect. And then the other category that I have over here is actually what sheltering is, and that is if you're not exposed, you may decide just to keep your kids home so they don't get exposed. So we have cases, people who have been exposed, and then people who haven't been exposed. Then you have scenarios where people are mixing, where I don't know the status of people in here, correct? So in this setting where we're mixing, that's where the whole category of social distancing comes in. Canceling mass gatherings, cancellation of classes, travel restrictions. We're trying to minimize the contact between people that may be infected. I'm sorry. And then the other ones up down there: antiviral drug distribution, vaccine distribution and use, and that's a huge topic that we are focusing in our center on that area. The whole issue of prioritization, distribution, allocation, administration, infection control, environmental health and animal health services, medical and mental health, healthcare and surge capacity, and then the whole area of public health communications. So this is just public health and medical response. There's all the legal issues. There's a lot of ethical issues, cultural issues, economic. It's a huge area. So I just want to show you that outline. In the back, I'm not going to go through it, but in preparedness, this is the way we sort of think about these disasters. And you can see from the very top to the very bottom. At the very bottom, it's focused on public health outbreak surveillance, investigation, and containment. So this gives you a quick overview of how public health is thinking about this. You don't hear a lot about this in the news, and I'm going to go ahead and turn it over to Eva.
Okay. Well, thanks. What I'd like to do is just give a moment of context and then say a little bit about a different aspect of what we do about influenza, at least the kind of work that I do. So I think the context here is when you think about diseases and globalization, infectious diseases are obviously or at the top of the list in terms of diseases that in essence are global and really don't have borders. And whether those are sexually transmitted diseases because people travel and have sex, or whether it's because of food and water or a vector-borne disease, all of the diseases, all the infectious diseases basically can quickly move from one part of the globe to the other, but perhaps none of them more quickly than influenza. And so we've known for a long time from prior flu pandemics that in essence we're a single global community. There are a lot of issues about, in fact, where the virus causing this pandemic originated. Did it in fact originate in Mexico? Did it in fact originate perhaps outside of Mexico and get brought into Mexico? So there are a lot of issues that relate to that. But I think influenza and this pandemic actually illustrate a number of points. The first is that in terms of where viruses and infectious agents originate, there are a number of interesting questions, both in terms of corporations and how they act, as well as the public sector and how it is prepared and how it reacts, in terms of how infectious agents spread, and then in terms of what the possibilities are for containment and control of infectious diseases. And they all point out the necessity for government sector to work, for the private sector to work, and for individual and community groups to all be involved. So just in terms of what we're doing, for about the last 5 years, our California Emerging Infections Program has actually been doing influenza surveillance here in the 3 Bay Area counties. Alameda, Contra Costa, San Francisco. And I think this is a nice example of an academic public health department partnership, because it involves both the California Department of Public Health, the county health departments, and those of us here at Berkeley. And so we've actually been doing hospital-based, laboratory-based surveillance for flu for the last 5 or 6 years. We collect viral isolates. We monitor what isolates are circulating in the community. We do studies looking at the effectiveness of flu vaccine, as well as looking at the factors that influence your risk of getting influenza. So there certainly is plenty of capacity to do those kinds of studies, but there's no question this most recent pandemic, which fortunately so far is producing relatively mild illness for the most part, is testing that system and is certainly going to provide a lot of challenges going forward. So we also connect in many ways with an international piece, but I'll let Eva talk about that.
Hi. So I'm going to talk first about just specifically related to the influenza and the swine flu, but I do have some thoughts about linking it to this morning. I don't know if that should come after that or... Anyway, so let me just start. In relation, so we are heavily involved right now in the international aspect of the swine flu and potential pandemic, specifically in Nicaragua. But where that came from is essentially over 20 years that I've been working in Nicaragua, as well as students and others in my group, in working with the Ministry of Health on infectious diseases, and most recently for the last 10, 15 years on dengue. Dengue is a big public health problem. It's a viral disease, and we have been approaching it on a number of different levels, looking in hospitals and looking in the community in what's called a cohort study, where you follow children over time, and then you can understand a lot about the national transmission and develop sites for potential drug trials and vaccine trials. And so what we noticed is that we had maybe 50,000, 70,000 consults, and actually only about 100, 200 or so cases of dengue. So something else was going on, and we have all this pristine data that's very, very carefully monitored. And so so this is the story. So Aubrey is in the epi department and takes her qualifying exam and pulls out of the, you just pick a topic that's not your topic, and she picks influenza. And so she happens to be living in Nicaragua at the time and says, geez, we know nothing about influenza here. And it's true, there's nothing known about influenza in the tropics in general. So all the pandemic models are built on what we know in the northern hemisphere, and in the southern hemisphere, and then this blank around the middle of the world. And so, but everyone says, oh, well, it's not seasonal. And you look at the Ministry of Health data, and it's flat. For respiratory infections, it's flat across the year. But we looked in our cohort on the last 2 or 3 years of really careful data, and we see these peaks like this. Okay, so June, July, we have this huge peak, which is right over the southern hemisphere. And then in some years, we see a peak in November, December, which is right over our peak. So there is seasonal. So then we start a big prospective study. So this is laying on the infrastructure that we already have going. So it's really very efficient. And we just start taking now actual swabs, and then we test. And in fact, we do have influenza. And for 4 years now, we have these same peaks that nobody had noticed because no one had the data to look at it. But in the meantime, what that served to do is to actually help Nicaragua become a national influenza center with the WHO, World Health Organization, and to actually get their laboratory up and running on all of the molecular techniques. So PCR, RT-PCR, which is reverse transcriptase polymerase chain reaction, and then virus isolation. We have like a 95% isolation rate. We've actually become one of the best suppliers of viral isolates, because they're all being sequenced full length at some of the centers here. And and in the meantime, we started saying, well, there's other respiratory viruses. So we taught, and we've been working for so long there that it was very easy to, they've been struggling to do this with the WHO and the CDC for like 10 years. And within 2 months, it was all up and running. But then that allowed them to respond to national epidemics. So we started looking at other respiratory infections. And then there was this huge outbreak of respiratory syncytial virus, but no one knew what it was. It was just this huge number of infants were really sick and dying. And so because they had the capacity right there, even though they called in the CDC, by the time the CDC came, they actually had all of the samples analyzed. And so it's essentially, we're now building capacity to this have essentially first response. And Nicaragua, which happens to be the second poorest country in the hemisphere. So now come along influenza, now the swine flu. So immediately we can actually just feed that right in, because now we have people there. We've got the machines ready to go. And so Aubrey Gordon, who's one of our graduate students, and 2 graduate students actually are now down there this week. And yesterday we were able to set up the PCR for detection of swine flu at the national, in Nicaragua. So now that's serving for the national essential requirements. But it also, we've actually been approached by CDC in Central America as well as Atlanta to potentially be the regional center for Central America, because it's right there and the people are trained and they're ready to go, and it's actually being set up. So it's and so that's really important in terms of a public health response, in the middle of this developing countries around the tropics, where in theory there was no influenza, but we're actually now going into our peak influenza season. So we're quite sure that we're going to see something. So that's kind of on the public health or epidemiological front. But on the research front, this is actually a really great opportunity, because there's a lot that we just don't know about how influenza is transmitted, especially in the tropics. And so, but since we have this cohort set up where we actually have children that we're following, and they're consented and they already know about the study and they understand what we're trying to understand about disease, we can actually do what's called a household transmission study, which is where you go right away to a child's house and then you sample everyone around them who are healthy, but then you keep sampling, and so you can actually see who has the virus, how long it takes them to become sick, how long they're sick, they actually have influenza while they're sick. And you can define really crucial aspects about what we need to know about swine flu in general, and flu in general, because, and so we can actually do that in real time starting now, because we've actually already, set up the study to do this. And so I think this is going to be really important from both the public health aspect as well as from the research, because then we can understand, for instance, how long are people shedding virus, even when they're not sick. And so this will then feed into to the work that Tomas is doing and Art and all the models, because not only do you need to know that at the microbiological or virological level, but we actually need to fit in the tropical countries, which are clearly having seasonal epidemics, into the pandemic models, because otherwise the pandemic models are wrong, and they're going to have different conclusions which aren't based on reality. So that's just kind of something that I wanted to mention in terms of the following, how we're directly related to this particular swine flu pandemic. And then I don't know how we want to address some of the other questions, because I have some other thoughts.
Open it up to the audience first, and then if you have questions. And if you can ask questions that are related to maybe this epidemic swine flu, but again in the context of what we discussed this morning. If you have specific questions like those, please go ahead and ask. Otherwise, we'll have each of the panels, discuss those issues.
Well, the last big flu, of course, was the 1918 flu, in terms of actually having an impact on the burden of disease in the world, in terms of a pandemic flu. Now we have, we're talking about global change. We have a lot more people, a lot more cities, people in cities. We have a lot more communication, a lot more transportation. How have those changes that we're talking about here affected the prospect of another pandemic flu of this, as fatal as, as devastating as that one? Are we less likely? Let's put it another way. If we had the same flu emerge today as in 1918, would it be a bigger epidemic or a smaller one?
Well, I guess the first thing to say is, if you mean by bigger, you mean the total number of people. It certainly would be a larger total number of people. If you mean in terms of what proportion of the people on the earth who would be affected, it's not clear the overall proportion would be any different. I think clearly the big question is how much morbidity and mortality would there be. And there's no question that this virus in particular is already basically a global virus. What's uncertain is how much it will evolve, and whether it will evolve in the direction of being even a milder virus that disappears effectively, or of much more concern evolving to a much more pathogenic virus. On the good side, we do have oxygen, we do have antibiotics for treating secondary bacterial infections, and we have the capacity to make a vaccine in a much shorter period of time. Of course, there were no vaccines in 1918 against influenza. Of course, from a global point of view, as I think many people know, if this is truly a new virus, as it appears to be, and if you therefore need 2 doses of vaccine, and the world has 6 billion people, that's 12 billion doses of vaccine you would need to protect the world, and current global capacity would take a little over 4 years to make that much of a new flu vaccine. So in the meantime, of course, there could be a lot of morbidity and mortality, and we'd have to do the best we could with what Tomas was talking about. And I have to tell you that I think in general, social distancing and the other mechanisms we have, like coughing into your elbow, as Tomas just did, probably are not very effective at preventing transmission of influenza.
Well, I think one of the big issues also is like here, I mean, the press has become very, oh, well, thank goodness it's not so bad anyways. All right, next. Well, 96% of deaths from influenza are expected to occur in developing countries. And so, there's... And they're not the ones who are going to get the first batch of vaccine. There's no Tamiflu in like the country of Nicaragua, and so this is where the problem is. And I think so. And it also is mostly a problem when you get these really acute peaks. And influenza can do that. I mean, in fact, you get very, very like 2 weeks is practically your whole peak. And when that is gazillion people, I mean, every pyramid of infectious disease, you have, you have essentially people who are infected and not symptomatic, and then who are mild, and then the very tip are the people who die. So if you push that up, instead of having 10,000 people, infected, you have now 10 million people infected. You're obviously, even if it's not any more lethal than just the regular flu, you're still going to have huge numbers of people dying just because of the number, that are infected in that pyramid. And so I think that, for me, I'd still have great concern, especially thinking about how all that's going to play out in the developing world. And so, like in Nicaragua, they're doing a really amazing job right now of preparedness, and so in terms of they know it's coming, so they've actually already set up whole, like the schools are where all of the people and children who have respiratory illnesses are actually going to be seen at a school, and the rest of people are going to the health center. So if you have a respiratory anything, you're not coming to the health center or a hospital. They're not sending anyone to health. Instead, they're having doctors go to schools. I mean, not schools that are functional, right? I mean, they're going to close the schools, and have doctors set up, which of course is, we have our study, and we're trying to split everybody into pieces, But the point is that they're doing a lot in terms of more than social distancing, which is kind of what they have to use right now. And the idea is that if you can make that peak be a little bit less acute, and even if there are a lot of people are going to get infected, but you can make it broader instead of everybody getting infected at once, then you have a much better chance of controlling at least the mortality.
I'm going to be a little optimistic. In 1918, when influenza struck, nobody knew it was influenza. They didn't know what it was. They didn't know how it was transmitted. No diagnostic tools, no vaccine, no treatment. So basically, I think in many ways we're a lot better off today because we can, we have surveillance tools. We do have medical care systems. But one of the frustrating things is that even though actually the H1N1 is a really good example, our surveillance is telling us where it is, and guess what? It's all over the world, and there wasn't much that we could do to stop it. So it really is humbling, and I think for us, I think the surveillance is really key because it not only tells us where it is, but it's also really important for us to measure the morbidity and mortality because a lot of the decisions of what we do and how people respond is going to depend on how deadly it appears. And the other thing is public's perceptions of risk. So in 1918, the average mortality was estimated to be around 2%. When you think of it from a public health perspective and you think of an epidemic moving through a population with a lot of morbidity and 2% of people dying in a short period of time, it'll cause a lot of economic and social disruption. But you go out there and talk to the average person, they say 2%, well, that means 98% of people survive, so it doesn't sound so bad. And I hear this sometimes, and I think even right now with a mild case, you hear some backlash from the public that there was overreaction, right? SARS, the overall mortality rate for SARS was 11%, no vaccine, no treatment, and 50% mortality in people above 50. Fortunately, it wasn't as transmissible as influenza. So anyway, so what we perceive from a public health perspective as being of bigger concern, the public may not perceive it the same way. And I think that's one of our challenges is communicating this risk in a way that makes our public health control measures more effective.
So My question is prefaced by a sort of report from the ground. 2 of my 3 children are at Malcolm X School, which is the one school in Berkeley that was closed. I happened to be out of town at the time, so my mom had to deal with this. And basically, people responded like they respond to any other crisis. We got together in groups, we pooled our kids so that people could go to work. So the social distancing thing didn't happen. And part of why it didn't happen is because I think people didn't feel that there was a need for it. There was a general perception of overreaction. At the same time, I'm flying across the country to Florida and seeing on the news in the airports, all this sort of what seemed like hysteria, So I guess I'm left kind of wondering, as a parent, as a public health person, was this a success in terms of being able to track this potential epidemic and stop it from spreading? Was it an overreaction? How is what we learned from this particular situation going to affect the next time this happens?
If you think about this, just think about how quickly everything happened. Within a matter really of a few weeks, we had a pretty quick idea that this was pretty mild. That's actually very, very impressive. Remember, I told you 1918, the mortality rate was about 2%. Imagine it had been about 3%. Just being able to measure that, to pick that up would have been difficult. So imagine if we had gone weeks and months before we really figured it out. And in the meantime, we have all this uncertainty. Your children are getting exposed. So I would say that things move relatively fast. I'm just shocked how over the weekend the CDC closed the schools for 2 weeks, and by Monday morning it was let the schools go back. I mean, there was just a lot of information was flowing in that everybody was saying, okay, maybe we can back off, and I think that has to do with the fact that we have these systems and diagnostic tools in place. Yeah, how there's a gap between what you're saying and what the perception is? No, absolutely. I would say we weren't successful in terms of containment. We weren't successful, so we should take containment off the table. But anyway, that's all. I'm going to let them give their 2 cents.
Are these okay? I just want to bring in the other things from this morning instead.
Hello? Yeah. I think Art was saying how infectious disease is really creating a global community. And I'm wondering, in the wake of the swine flu and all of this attention towards how we really are linked as a global community, and the fear and the pandemonium which precipitated so much media coverage and so much thinking about swine flu, how we can use that fear or capitalize on that global community created by infectious disease to address some of the challenges that were talked about in the other 2 parts of the presentation around urbanization and climate change.
Okay, I mean, so one thing, I don't like to base things on fear, but one thing that sort of that's a no-brainer is we should have universal access to medical care, right? We should, I mean, that's one of the things about when you have these kinds of issues, it sort of reveals the cracks in the system, and so it reveals the fact that we have people that don't get sick days, don't have access to daycare, don't have access to medical care services, and that's where these epidemics can be transmitting. And so this is sort of an opportunity to remind people that we are a community, all of us, and we all should have the same rights in those respects.
Just to link it back to some of the kind of links between those larger issues and health. Just some things I've been thinking about that I wanted to get out there where I think there is a research agenda that's really important that could maybe come out of this. Because, so we were talking about specifically, like say climate change, urbanization, or economic globalization, but really it's kind of like everything. It's the life world of the person, you know. And so, I mean, we have this project in Nicaragua looking at essentially dengue in communities and essentially bringing evidence to communities to have them make their own decisions about controlling the mosquitoes that transmit dengue. And you can do that very simply. And the whole question has been using evidence, especially it very much connects to that, to the risk assessment question, but essentially making a decision to take a preventive action. And it's a personal decision in each case. But what ended up happening is that we came in with the dengue as the banner and this evidence and their decision, but the whole involvement of the community around a health issue and then with each other and then with other communities ended up being essentially social mobilization. And so then we started seeing changes in lowering delinquency, people feeling, you know, essentially safer, them having more of a voice in governance and feeling heard as citizens. And so, you know, it starts actually going much out into what is going to be the next panel, the whole issue of vulnerability. So essentially, you know, by having a focused work or program on health, it actually affects other things. And then conversely, all those other things, essentially the life world, actually has more of an impact on health than any one intervention, like here, take this one medication for this one thing. You know, and so it's really linking it in both directions. And what we need is actually data to support that, is what I feel, because it's very, we actually were measuring this, but most of the time, and in one of my classes I teach, it came out that a lot of different interventions and different stories were being told, but the ones that actually dealt with where the larger life world of the people make the difference in their health, there's no data on that. It's very anecdotal. And people often react, especially policy and, you know, to data. And I think that we have an opportunity to actually, you know, try and beef up both health outcomes, you know, disease measurements, et cetera, on these larger impacts on globalization, I mean, on economics, on how it changes the life world of people, and then vice versa, how, you know, how health essentially programs can impact the rest. And I think it's really important to link that. One of my students gave a presentation just a few days ago in a class that we were talking about how microcredit could really, if you look at everything, you say, oh my God, this is so terrible. How do you help? Where do you start? And you say, well, you start by making people have their own, you know, essentially economic autonomy, and then it helps with the gender question, and it helps, et cetera. And it helps on health. But again, looking in the literature, there's very little that shows how microcredit is linked to health. And what there was is they found that a lot of times the microcredit programs would fail when there was a health emergency, because then the microloans had to stop into the little, you know, whatever they're doing, making baskets or what have you, and, you know, and then be diverted into the health emergency. So actually some of there was programs where the banks felt that it was actually useful for them to have a healthcare insurance program alongside the microcredit, and those were actually the most successful. The combination of the microcredit and the health insurance actually were more successful than either one alone. Because, you know, then and it actually was a good business model, in fact. And so, but there's very little data on this. I think that, you know, there's a lot that we can do here, thinking about, you know, health as what we're measuring, but then, you know, bringing in all these other aspects, and then that will generate the data upon which we can actually make policy movement.
If I may just comment, just in terms of reference to what we've been talking about today. So I think, as Thomas pointed out, we learned a lot of, I think, lessons just from this swine flu epidemic, in that it brought out a lot of vulnerabilities, even issues related to, what about daycare? You know, if this was a more virulent virus, what would we have done? And also, why did this epidemic start in a non-flu season? Why did it start in Mexico? These all, I think, all have to do with probably climate change. You know, traditionally seasonal flu begins in Asia, but it's now beginning right next door. And so these are, I think, this was kind of a nature's way of testing us. But next time, we may not have this leisure. And so I think we need to really be addressing some of the issues that I think we talked about this morning, and apply it so that we don't have a disaster like Katrina equivalent of the influenza next time. And so. Any other? Do we have any more time? Okay. Wait.
Yes. So one of the interesting things about Steve's talk this morning was pointing out how the politicians and the press look superficially at information and jump to conclusions. And this is certainly done in the context of global warming, but it's also was done in the context of influenza. And as far as the general public are concerned, pandemics can be very bad because 2.5% death rate was during the Spanish flu. But on Monday, when I took a look at some papers that I'd never looked at before, I actually got an incredible shock to see what the data really tells us about influenza epidemics. And that is, prior to the Second World War, the death rates were very high during normal epidemics. And they started coming down in the 1950s, and by the 1960s they were relatively low. And even during the pandemics of the 1960s, the Hong Kong flu and others, the death rates remained relatively low. So during a pandemic, because people are more susceptible to new viral strains, maybe 2 to 3 times as many people might get it. So instead of 5 to 10% getting it, maybe 10 to 20% get influenza. But at the same time, there's no good evidence that current medical practices aren't going to cope very well, except for traditional classes that normally die from influenza. And those are people over 80 or in the 80s. And so when we look at information, we never break it down. We look at it at a very aggregated, superficial level. We don't say what are the age classes of individuals dying. Obviously, there are important signifiers, and that is if young people are dying, then we know that this is a problematic strain and this is unusual. But even then, there's very good evidence that in societies where we have access to very good health care, it's not going to really be that much of a problem. And the real problem is access is not the influenza pandemic itself, but what access people have to healthcare when the influenza season comes around. And if it's a pandemic season, it may not be that bad in the United States, and it may not be that bad in Europe, provided there's adequate healthcare for everybody. So I think that's the real issue.
Any final words of wisdom? No? I agree. Time for one more. Okay.
Thank you. It's actually following up on your point. I wanted to ask the panel, but please answer me in terms of what can Berkeley do. In terms of comorbidities, I mean, we know that we are looking at who is dying, but in terms of access to healthcare, but I'm also thinking about comorbidities in terms of, we have large populations that are immune compromised already. We have a lot of TB out there, some of them latent TB, and we have HIV. I mean, how can we prepare ourselves to deal with those issues in terms, and how can that affect mortality? Even if, a lot of experts are saying that it's not as bad as the 1918 in terms of mortality, but how can that change?
Me? You're talking about specifically in terms of this swine flu virus? Well, I think, first of all, at the moment, we don't necessarily know that those groups will be at higher risk in terms of this virus, and we don't know what this virus will do in the future. But I think, from a preparedness point of view, in addition to what Tomas said, and things such as stockpiles of antivirals, which may or may not turn out to be helpful, clearly a huge public health policy question at the moment is the possible production of a vaccine. And how soon could we have how many doses? What will be the safety concerns about that vaccine, because there will be safety concerns about that vaccine, and then who should get priority for getting it, either in rich countries or between rich and poor countries. So there's a lot to be discussed around that, but ultimately I'm not sure that individuals with HIV or individuals with other underlying problems by themselves can actually do a great deal. Maybe I'm missing something, but
I think that brings up another point that I know Sochil has been, concerned about. That I think is a false complacency. Oh, look, it's not so bad. It's not so bad because there were few cases in California, and a few cases. If you hit the Central Valley, which is and where all our undocumented migrant workers are, that do not have access to health care and are in poorer health to begin with, then we're going to see problems. We don't know this yet because those are the vulnerable populations which we're not exposed yet, and so I think what we can do, we have programs in, a lot of these vulnerable populations at Berkeley, so setting up a system now in advance would be something, for instance, and getting that information. But I don't think we can say, oh, hey, not a problem, because it didn't hit some of the populations that are going to be most vulnerable. And actually, this one did go, some of the ages affected were 20 to 40 range, in Imperial County and San Diego and others. And so I think that, that was very unusual, which, usually it's the very young and the very old. And this strain was going into the populations which are considered where, pandemic strains, in fact. And so I think that there is still cause to be careful and to look at where we might expect those vulnerabilities and do something about it now.
Yeah, this is sort of the typical, what I call a public health paradox, in that if you actually do something, public health, and prevent something from happening, then you get blamed for overreacting. But maybe it's because of what they did and what they've been doing up to now that we didn't have the epidemic that we may have had. And this is, I think, even true in Mexico. People thought they were overreacting in Mexico, but I think it would have been a lot worse if they had not done what they have done. And we don't know that until now, until after we've done all these things. And unfortunately, people in public health, they're not like surgeons. We don't get credit for doing these things. So we don't get credit for preventing something from happening.
That's what I was going to say. One more question.
As far as the overreaction is concerned, it reminds me when you go see a house on fire and there's 4 fire trucks there and they only need 1. That's an overreaction on a fire department. No, it's not. It's to make sure that in case that fire really spreads, they've got the facilities right there to take care of it. And I think the health department done a marvelous job in this country and wherever else. I have a more practical question. I read once that if you're going to vaccinate a population with an effective vaccine, that you don't have to vaccinate the entire population. You only have to vaccinate, what, 50%? Or what is the crucial percentage?
And you each can give one answer.
So you're referring to a concept, in essence, that is referred to as herd immunity. And so, yes, in theory, it's correct that if I manage to achieve immunity in a large proportion of the population, some people will be indirectly protected. But what proportion depends on how infectious that agent is. And so if you're talking about a virus like this in which no one starts out with immunity, and you're talking about a virus which is one of the most transmissible viruses we know, the quick answer is you'd have to achieve an extraordinarily high level of coverage to see very much indirect protection. So I personally wouldn't want to rely on it.
No, and in general, it's a dangerous concept. I mean, it's useful for infectious disease people, but the concept of that has now spread. Well, I don't really need to get vaccinated. I don't want that risk for my kid. And so, I mean, I have a doctoral student in my laboratory who all of her roommates have whooping cough. They literally, I was like, what is this? Like, the 18th century? I mean, what's going on here? And it's because there's people who choose not to get vaccinated, and then it's not necessarily them, but because, there are children who are not getting vaccinated, because it's essentially because of this, again, risk question. It's seen that, it's not a risk I need to take, but then if all those people don't take that, decide not to take that risk, then all of us are at a much greater risk, and vaccines won't work, because it's just going to spread through the population. And then if you haven't had a whooping cough vaccine, for 10 or more years, because, why should you keep getting it? It's supposed to be for kids, then it will spread into adult populations as well. So it's really important to, that the whole concept of the vaccines working in a population means that everybody is getting vaccinated when they're supposed to, and otherwise it falls apart.
Okay, join me in thanking you.
Thank you.
Okay, our moderator for this panel is Ndola Prada. Ndola is a scientific director of the Bixby Center and a professor of population and family planning. Or no, maternal and child health. Got it. Or, no, okay.
It's all good. So thank you everybody for staying until the last panel. This is a panel on vulnerability, and we are looking at focusing on broader definitions of health, looking at the responses to poor access to essential medicines and general healthcare services, addressing inequities, and most importantly, how to reduce vulnerabilities in specific subpopulations. I will introduce very quickly my panel so we can move on to the discussions. And I will start with the lady, Xochitl Castañeda. She's a medical anthropologist. She's also the director of health initiatives for America. And she works on immigrant health issues. Jason Coburn, he's assistant professor of city and regional planning. He's also on the faculty in global metro studies and works on urban health equity issues. Malcolm Potts is a professor of population and family planning. He's the chair of the Bixby Center for Population Health and Sustainability, and works in evolutionary biology, family planning, and a true champion for many issues of women's health. So the way we're going to do in this panel is that I will going to give each of the panelists 1 minute for opening remarks. Then I'm going to ask a few specific questions focusing on solutions that they can propose through the lenses of their field. And then I will open the discussion to the audience. So let's start with Xochitl.
Well, 1 minute. So I work for and with immigrants here in the United States and in various countries of Latin America. What I have learned is that vulnerabilities are experienced differently according to, for example, gender issues, ethnic issues, but also community and policy large issues. One of the things that for immigrants is particular, I think, is the perception of risk, and that has to deal with the many risks they face in a day-to-day environment. For example, the risk for crossing, for example, undocumentedly. It's a big risk, the risk of having a secure job, or the conditions they live, the type of work they perform, the access to the services, the capacity of understanding the language or the fragmented system in the United States place them at different levels of vulnerability. But also I want to stress the political issues, and I think the regulation of human flows, in this case between Mexico or Latin America and the United States, it's a factor that we have to consider when talking about vulnerabilities. Can I talk more or that's? Well, for example, in relation to the perception of risks, the fact that the majority of the workers of Mexico are undocumented make them to be clandestine in this country. And when you are clandestine, you experience some disempowerment. And also, you develop certain resiliencies to reinvent yourself vis-a-vis the obstacles that you have to face. So those social issues, and I am an anthropologist and a dreamer, I think we need to consider when creating public policies and trying to address vulnerabilities in this population, concretely the immigrants.
Okay, 1 minute. Okay, I'm from New York. I can probably do this. I'm also from city planning. I didn't see many other city planners in the room here. That would be one suggestion for later about how we move this forward. But when I think about vulnerability in the urban context, I think both from a practice and research perspective, we need to think more critically about what we mean by place and how places differ and exposures differ across places. I've been talking about diseases, we've been talking about risk factors, but what about places as places of vulnerability and how the multiple facets of place, so housing, transportation, access to services, including food, affordable and healthy food, access to places for recreation, social interaction, all of that comes together or doesn't come together in particular places. So I think we need to rethink how we define urban vulnerability around robust notions of places. And it's not just measuring static variables of places, but thinking about the interactions of these multiple facets of places. So you've got built and social environments, traditional environmental exposures. There's also, importantly, what we don't think about and what we're trying to think more about in planning, and I know in public policy, is the role of public institutions and public decision-making as either promoting or being able to prevent vulnerability in particular places. We often write policy and do interventions for populations, but not for places. So how do we rethink our strategies using a place-based approach? And I would say one more thing about that, and then we'll pass it on, is that part of thinking robustly about places is about rich and meaningful participation and community engagement. And this is not at the end of a study to get buy-in, but it's in defining the research questions and the intervention strategies up front. It's about democratizing the actual science and the policy making at the same time. Not thinking that the science will be done in the lab and then we'll bring it to the street or into the community and we'll sell it to people as an effective intervention. But bringing community members into the research design and research process is, I think, critical in order to understand this robust notion of place vulnerability.
I want to go back to some of the things that Alex Eze said. Slum populations in Africa are doubling every 15 years. By 2050, there'll be more people in Africa living in slums than there are people in the United States of America. Next time you fly across this country to tell people to ride on bicycles, just look down at all the cities you're crossing. Look at all the people you're passing in the street, all the people in the airport, and think of that number of people living in slums. I think everybody in a slum is vulnerable. You've got shit in the road outside. You've got your children having diarrhea, a third of them having diarrhea every 2 weeks. You've got domestic violence. You've got no privacy. You've got a tin roof. It's too hot unbearably hot in the summer. It can be quite cold in the winter. 48% of the births in Zambia are unintended. I think we need to put enormous weight on offering people family planning choices, learn that family planning is listening to what women want, not telling them what to do. And that I think we have enormous opportunities to ameliorate some of these problems. And that rapid population growth, when it's driven by unintended pregnancies, is the ultimate threat multiplier. And we can come back to what to do about this in a moment.
Thank you so much. So, Suchil, what I wanted to ask, and in order to start the discussion, is we've heard in the morning what Alex has mentioned and the other keynote speakers in terms of enormous migration that is expected to happen, and also the growth in urban areas that we expect to happen, and the increasing poverty. So, in your view, what can you propose that Berkeley can focus on, or what can Berkeley do in terms of gathering more knowledge or research or anything that can make us better understand the situation?
Okay. You're great, Mia. It's a great opportunity to share what we are doing here at Berkeley. First of all, there is the image that, for example, Mexicans come from rural areas to work in rural areas here. Let me share with you that 65% of the Mexican origin population come to mega cities in the United States. So what we have tried to do, and I don't think it's a solution, I think it's like putting a Band-Aid in a hemorrhage because the problems are structural. And what we have been doing is working at 3 levels. First, we have been working in the research arena, inviting binational teams of researchers. We have now 52 teams of researchers conducting relevant research on migration and health issues in a variety of topics that are the most important and that we need to document how migration is impacting the health of this population. And this is something that is unique in the world, and we are seeing now results of that research. We are training people on how to approach this mobile population. And when say training people, we are not just training students. We have, for example, a summer institute that brings over 100 students to Mexico, but we are also training the future physicians on how to address even the perception of illness or the body that is different from these populations that come from different settings and different cultures. And in the assistential part, that is what I think we are more proud because it's really public health practice. We are mobilizing existing networks throughout the country of a variety of stakeholders. We don't think health just stays in the medical domain. So for example, we do an event every year that is called Binational Health Week. And we have over 22,000 volunteers working in that event with the UC Berkeley here at the School of Public Health. And what we do is we provide assistential services to this population. And let me tell you, in research that we conducted, a survey that we conducted last year, 30% of the over 500,000 people we provided services said it was the first time ever they receive a health service in the United States, some of them with 10 years or more. So their health capital is deteriorating because they are afraid to seek the services. So the approach that we have been taking is more like use the population they trust. So a lot of our efforts are with promotoras, with the consulates, and with non-traditional approaches on public health.
Thank you, Xochitl. Jason, to you, because you're an urban city planner and work on equity issues, I want you to address a little bit the health impact of non-health interventions. You know, what do we do? Where do we start in terms of urban planning, in terms of environmental preservation, given the problems that we have?
Good question. I would echo what folks said this morning in the sense that we need to move from problem analysis to solution analysis and begin to be as experimental and robust in solutions as we are in analyzing and documenting problems. And we've done a pretty good job, I think, of that. I would agree with Trevor and others that we know enough to intervene. But what we haven't done, even when we have intervened, is put robust monitoring and tracking systems in place to learn as we go. Listen, we're going to be wrong more times than we're right, even though we don't want to admit that in public health or in city planning. City planning, we've clearly been wrong more than we've been right. So what we need to do is to track ourselves and to track how places and populations are doing as we intervene. So we need to, I think, the first thing is to generate experimental solutions and in a sort of accompanying those are robust tracking and monitoring systems. So one concrete example is the use of health impact assessment, which is widely used by the World Health Organization in places like Canada, Australia, and Europe, gaining resonance around the world, slowly gaining in practice here in the Bay Area and in other parts of the U.S. The CDC and others are now putting out RFPs for HIA practice. It's a growing field in the United States, but there's a lot to be learned from a decade or two of practice around the world, both of how to do this, how to apply it to non-health policies, how to apply it to places, and how to include rich research and monitoring along with the HIA process. So I would say that's one thing we ought to be training people in their MPH program and how to do this work. We do have a course in health impact assessment here at UC Berkeley that most people probably don't know about. It's actually co-taught between School of Public Health and Department of City Planning. I would just echo what I said earlier about strategies to look comprehensively at places and switch and sort of flip around what we do now in public health to look at diseases and risk factors. And you're saying, well, that's ridiculous, that's crazy. How do we do that? How do we make places better? Don't we need to just look at populations and exposures? Well, in fact, there are many other folks who are saying this. I would argue that if, you know, the WHO social determinants report that that Trevor mentioned and Alex's work on slum health is really about place-based improving health by improving the qualities of places. And in fact, the California Endowment, the largest health funder in the state of California, has redesigned almost their entire funding strategy around places. They've picked the 14 most vulnerable places in the state of California, and they have a 10-plus year strategy, a multi-pronged strategy to intervene, everything from social network building and building local institutions to health care to housing, transportation, and an integrated, what hopefully will be an integrated strategy. I'm working with them in Richmond on this particular project. I would also say that we need to, both in our practice institutions and in our public health, how we're training people, is to move away from the sort of segmentation again, of diseases and risk factors, and begin to train people more in interventions and thinking about what is a healthy place. Not what are the problems in a place, we again do that well, but what are the qualities, characteristics, and again the political institutions that make places or could make places more healthy, and who do we have to include in that, the notion of governance. Our public health departments are set up around diseases and risk factors. Much of the research we do is also not necessarily around healthy places and particularly health equity in places. So I would say those are at least two specific strategies to move towards a sort of reshifting, redefining the public health paradigm around a healthy urban place.
Thank you. Malcolm, because of the age structure and gender structure of the world's population, and giving the projections that Alex presented, I see that in the developing world, most of the vulnerable populations are going to be women, and they're going to be the poor. So where do we start?
One place to start is where Trevor mentioned this morning. Look at the successes, even if they're few and far between. The total fertility rate, the average number of children in Addis Ababa, which is a very poor capital in Africa, is now 2 or less. Let's have some anthropologists, some demographers that do their PhDs on why that has happened. I have some ideas, but I'd love to see good research. One of the largest family planning programs in the world is here in California. It's Family Pact, run by UCSF. I think it's a brilliantly successful thing. It goes to a lot of very vulnerable groups within this state. And it really depends upon how you incentivize providers. Again, let's have people in the House Business School, in economics, looking at that aspect of it. Those are things that those of us that work well, you know, speaking for myself in family planning, I don't have those skills, but I think it's very important. So those are two good examples of research that would be very cross-disciplinary. And the goal, I'm looking at the last sentence in today's program. It says the goal of today's symposium is to share and synergize these experiences by setting the stage for an interdisciplinary solution-based approach to health. And I haven't heard as much of that as I would like to this afternoon. Look for things that we can do. And I would like to throw out a challenge to my faculty colleagues in this room, to Jim, to Michael, to Inez, to Eva, to Jason. I think that understanding the impact of rapid population growth and how damaging that is, understanding the unmet need for family planning and how we're failing to meet that we're not respecting women, we're not giving them the choices that they deserve. I think those are basic things that everybody that's interested in global health and public health should understand. And the Bixby Center, we've been given one lecture in some other courses in agriculture, in other areas. And I would like to volunteer my team to give a single lecture on the implications of rapid population growth, the fact that population is a variable which can be changed in a human rights framework in every course where that might be relevant. I think that would be very rewarding to the students, and we'd be very, very happy to do that. At a different level, somebody mentioned the 3 billion cell phones. I think that's an extraordinarily powerful technology. One of the things that prevents people using family planning is a great deal of misinformation. There's literally millions of women in this world who think a contraceptive is more dangerous than having a baby. How can we use cell phones to counter that misinformation? Lastly, I'm worried that the people that have sat on this little dais here are not the people that are going to solve this problem. Leah Marsh, will you put up your hands? Leah is an undergraduate. She's organized entirely by herself a decal class on poverty and population. Serena, sitting next to her, put up your hand. Serena's about to go to medical school. She had an absolutely stunning art exhibition in an art gallery across the road on Tuesday night. About 300 people came. They took each of them Millennium Development Goals. They got somebody to really do very sophisticated art, and then a large panel saying how population growth interacted with the Millennium Development Goals. I would never have thought of doing that. And they got people from all across the campus, not just bleeding heart public health people. And I think that the future is with the young ideas like that. And I'm proud to have such people in the team. And let's have more cross-disciplinary sharing and more sharing of information. Let's get out of our little silos. And so please, I challenge the people in this room, if you're giving a 101 course, Lee's nodding his head, then we're willing to provide, I think, at least an interesting and stimulating lecture to make people think about a very, very important variable. It's not sufficient to slow population growth, but in many of the things that we're looking at for vulnerable populations, it's a very necessary step. Thank you.
Thank you. Shall I open now for questions? Comments?
Hi, I just wanted to second Malcolm's point about, turn around. I wanted to second Malcolm's point about if there are classes that are being taught and there is an opportunity where we can integrate the different fields that we work in particular, in this case, population, I think it would be really useful. And one of the things that wasn't mentioned that I think really should be mentioned is the connection between Alex Aze's presentation, especially at the end, on where the clinics were, so the voucher system, where the women had the vouchers in their hand. They had purchased this voucher, and yet they still did not go to the clinic. And what were the reasons behind that? And part of it was the location, having to leave the slum area to go. And what does that have to do? That has to do with city planning and structure. And what is the relationship? I just think that it's really important that if there are opportunities for junior staff like myself or for students like Leah and Serena, I think it would be useful for our own learning and understanding, but also so that we're reaching a wider audience. So it's just more of a comment.
I always thought that the birth rate was related to the economic status of the people in terms of, for instance, in the Western nations, the native populations, whether it's Italy or France or even the United States, I call native in the sense that they were born there, have a birth rate barely reproducing themselves. But the immigrants who come keep furnishing the child until the immigrant generation makes enough money to enjoy the life, and then they cut down and go back to their so-called native birth rate. So it's all well and good to talk about you can talk about birth education, but until we improve their economic status, how's it going to reach them? If that was true, I would jump off the Golden Gate Bridge tomorrow. Because as Alex has demonstrated, with very rapid population growth, more than 3% in many parts of Africa, you're not going to get socioeconomic development. If you look at the educational bar charts you had, the educational achievements are going down. in somewhere like Niger that's going to go from 14 to 40 million people in the next 40 years. Education is a wonderful thing, and it's very important to invest in it, but it's not going to get ahead. The good news is, and this is relatively recent, and it's something that we particularly sort of highlight in Berkeley, and we're probably the leaders in doing this, is that we look at things from the client's point of view, from the woman's point of view. There are an enormous number of barriers that prevent poor and vulnerable women getting contraceptive advice. We were just whispering to other, immigrants in this country can't find somewhere to go to. Let's take the pill off prescription. There's no scientific basis for forcing a woman to go to a clinic and be demeaned by taking her panties off. Let her buy the pill next to extra-strength Tylenol. When we do those things, as we have done in Bangladesh, where the total fertility rate is now 2.7, and for tens of millions of people in Bangladesh, where 2/3 of the women are illiterate, where the infant mortality is still tragically high, the total fertility rate is 2.2. That is because for 30 years, or that I suggest, and we would like to suggest these ideas and share them for challenge and research by other groups. It seems to us that this is because these people have had access to contraception and safe abortion, and you don't have to be educated to want to have fewer children. It certainly makes it much easier, but and you don't have to be richer, so that we have these anomalies like Addis Ababa. We also have the reverse situation, and Kenya, where Alex has been documented this very well in his other publications. We had a strong focus on family planning. We had quite a very marked decline in the average number of children. Then it stalled for a long time because the focus was taken off family planning, and a lot of energy was put into AIDS prevention and into a broader number of things. Family planning needs a certain kind of in-your-face activity, but it needs to be based on information and voluntary choices. And if you do that, you can certainly slow fertility growth, and it's enormously important that we do that. So, in many parts of Africa, if you walk 15 kilometers to come to a clinic and you want to have a contraceptive, they won't give it to you if you're menstruating. There is no evidence base for that. In Tanzania, if you've had 5 children, they won't give you the pill. In Madagascar, if you haven't had a child, they won't give you the pill. We live in a patriarchal world where dumb physicians invent reasons why women shouldn't have access to contraception. And we have an enormous opportunity to document those and to do the operations research, and Professor Pratt has done a lot of this, that allows people to get the choices that they need and to change non-evidence-based restrictive practices that prevent women and men getting the choices that is their human right to have.
I just want to add that we cannot generalize about immigrants in general. There are variations, for example, between recent immigrants and the first generation. Let me tell you, in the case of Mexican immigrants, the recent women do not have the same fertility rates that they have in their communities of origin. 3 reasons may allow to that. Number 1, you don't have the same control of the community, so you don't have to enroll in the gender roles that are expected. Secondly, here the proportion male to female is enormous. For each woman you have 5 males, so you can choose among many ones. So you don't have to perform those traditional roles. And thirdly, the majority of recent immigrants are employed, so they do not have, the only option to have is to reproduce themselves. So I think it's just a little anthropology note.
So just to finalize with where family planning is, I think family planning is about choice. And the choice should be given to all women, regardless of their level of education, whether they're illiterate or they have higher education, whether they live in a country with the high economic development or not. They should have the choice to use. We, in the West, we have the technology, we have the knowledge, and I think that it's our obligation to make it available and affordable to poor women, the most vulnerable of this world.
I'm not really sure I want to say this because I'm actually quite pessimistic, but there seem to be enormously powerful religious and social conservative forces that in the face of all information to the contrary refuse to accept the facts as they are. I mean, if you have a look at the number of people in the United States with all their education who really have a problem accepting the facts of evolution, you really wonder what we can do in the end to convince people to change habits in the face of social and religious conservative forces. And to me, as I said, I wasn't sure that I really want to say this because I find it quite depressing. But we live in this isolated glass community here at Berkeley, and then when you look out at the rest of the country, you realize it's much more difficult to really institute change than we would like to think.
And perhaps we should join our colleagues from the Hill at the Berkeley Theological Union to enlist their support.
We've put a document called The World in 2050 on the table outside, which summarizes a meeting where we brought together about 40 experts from economics, David Canning from Harvard, people in national security, demography, family planning, energy. And we tried to look at the impact of population growth and also population decline, because half the world now has the two-child family or fewer, on what the world's going to look like in 2050. And it was certainly a very somber picture, particularly when you look at the interaction between rapid population growth, so we say, in relation to the problem of employment, and then security and violence and things like that. But we also came, and I don't want to think, that we're a small group of people saying some minority set of beliefs. First of all, this group drew attention to the fact that the attention's gone away from international family planning, and that's a tragedy. In Kenya, I'm quoting from this thing, as a result of diminished focus on family planning, the projected population in 2050 has been increased from 54 million to 83 million. Some observers predict that an increase of this magnitude may lead to food scarcity, crumbling infrastructure, and potentially to violent conflicts over scarce resources. I mean, Kenya in 2050 could be rather like Somalia, a totally failed state. I hope it won't be, and I hope we can accelerate fertility decline again. But on the good side, it said meeting the unmet need for family planning has been highly successful in slowing rapid population growth. Ready access to contraception and safe abortion has decreased family size, even in illiterate communities living on less than $1 a day. So I think it's certainly a somber picture, and I think what people said today about weapons of mass destruction and the threats of the 21st century are incredibly serious. But I think that's also presumably part of the thrust behind this meeting, that we live in an interconnected world. I think we're humanitarians who all want to see people suffering less. In reducing their suffering, we're also helping ourselves. That's very much a win-win situation. And so I think we need to use the skills of the faculty and of the students and their commitment and ingenuity to try and ameliorate some of these problems. Otherwise, we do jump off the Golden Gate Bridge. Which I don't want to do.
Thank you. I'd like to just thank all of our panelists. It's been a great day learning a lot about climate change. And actually, my question is directed more so for Dr. Coburn in regards to urban planning. I'm particularly interested in packaging waterborne illnesses, looking at interventions that not only say target malaria, but all of the other risk factors associated or health outcomes associated with waterborne or water-related illnesses. So in terms of urban planning and actual water management or closing up of a lot of the sewage systems, at this point, are there any estimates on the table? I had one professor mention that if every developed nation gave just 1/10 of 1% of their GDP or GNP, that essentially 21,000 deaths each day could be averted. So are there any estimates on the table for exactly how much it would cost to start with, let's say, with water issue since water is the main concern of climate change?
Yeah, it's a very good question. I don't have the data on this, but I do have some anecdotal evidence of, first, recent report just a week or two ago of an independent audit of the World Bank's spending. Believe it or not, the World Bank is supposed to be spending to alleviate poverty and improve health. But this independent report said, of the billions of dollars that's spent, particularly on this water and sanitation program, 88% of those interventions were justified based on public health improvements, but only about 5% of those had any evidence that they did improve a range of population health indicators after they were constructed. And I think the role of urban planning in this is again, not to segment out water and a single disease, but to look at the role of access to clean water and sewer and sanitation in the context of what makes a healthy place. If you've got access to water but the tap is locked or it's controlled by some local gang, or there's it's inequitable access, then you could put all the infrastructure in that you want, and it's still not going to reach the right people and potentially improve health. So there's questions of sort of thinking, again, holistically about how does water and sanitary interventions fit into a larger strategy of improving places, and in particular in slums. And I've actually also work in Nairobi, and what we've seen is that there's great variation in access to clean water and access to sanitary sewers across the populations within the same settlement, within the same slum. And too often the interventions that come from outside and from outside researchers say, well, just build it and you'll improve health, without looking at the variation and the social dynamics about access and quality and service and long-term maintenance and all the difficult questions that come into providing water. I would say, I don't know, are you a public health student, master's, doctoral student? Okay. I would, if you're not already, I would encourage you to enroll in our joint master's program in public health and city planning. Just a little free advertising here. But we are sort of trying to both look domestically and internationally at these kind of challenges, urban health equity. And we have a team right now from engineering, city planning, public health, geography, and other schools, really looking at this question of infrastructure improvement in urban slums and the kind of population health benefits that they provide.
One more question or comment?
Hi, I have a question for, is it Sochil? Hi, this is inspired from a comment that you made earlier about how perceptions of illness differ by culture. And climate change is such a large problem. I mean, it's sometimes really hard to get your hands around. So I'm wondering, from your field work, from your research, on the ground scale, did you see any bottom-up strategies that were particular to the cultures that you were working in to mitigate climate change? I know that Kirk Smith has been working on the stoves, the cook stoves, and I'm wondering if there's some solutions that you saw, or potential solutions, while in the field with the people on the ground.
Unfortunately, the population that I work here with is not more the conscious on ecological things. So for this year, we are starting a campaign that is called Viviendo Verde, Living Green, with the support of a famous Latin American writer, Isabel Allende, who is really devoting efforts into this, because we need to educate the population about, for example, recycling. In our countries, that do not exist in many areas. So it's something that we need to embrace and educate our population here. Of course, you cannot generalize, and it's an issue of class also. So not necessarily the working class is has all the knowledge needed to have some green responses. I don't know if that answers your question. If I have the microphone, I would like to ask another. I would like to, when we were invited to this panel, you asked us to think about solutions and about vulnerability, and you specialized on place-based strategies. I want to know if you have think about some good examples that the immigrant community can bring. For example, we are really linked to our communities of origin. And I will not say just by national efforts, but translocal efforts. And for example, what we have started is programs that complement what starts, for example, in Mexico, and we try to give continuity here. So in the place bases that you are working, I don't know if you have some strategies in working with this population that have a lot of mobility?
I have, to some extent, in New York with the Dominican and Puerto Rican population, but I would just say that what you mentioned is probably the place to start, is to start with what many people have mentioned today, is to start with what's working and with organizations that are already connecting with people on the ground, and not try to reinvent things. And often that means bringing in maybe a public health perspective to people who are working on housing, or people who are working on access to other basic goods and services, or human rights, or other issues. And so again, it's starting with this sort of physical and social infrastructure that's already in places, that people trust, that people already are connected with, and building out from there. I think that has shown to work in many parts of the world. And then to try to, again, build on success, as was mentioned before. There are, believe it or not, very vulnerable communities that survive day to day. How do they do it? We don't study that well. How do people get by? Comorbidities, lots of exposure, poverty, discrimination. People figure out ways. They innovate in their communities. They connect with others. There's a richness of learning that we need to take advantage of about how people actually move through their world, even under very dire circumstances, and learn lessons from that, and then try to replicate that, again, with a rich and deep understanding of the differences across context. Not to take best practices from one part of the world and implement it somewhere else, but to learn from different parts of the world, and to understand the richness of a place, its population, its place-based characteristics, and see what kind of interventions would work in this particular place with these kinds of characteristics.
I think we are going to have to stop here. Thank you, dear panelists, and thank everybody for your participation.
All right, before we proceed to the closing with Kirk Smith and Dean Shortell, we do have just a couple of minutes of kind of open discussion to bring up a few of the things that may have come up during the lunchtime conversations, or things that you are working on, or solutions that you have heard of or would be interested in sharing with the rest of the group. So I really invite kind of reflecting on the whole day, looking at what was spoken about the keynote speakers today, the panel this morning, the panels. Is there anything else that someone else would like to share at this time? Anyone? Yeah. Well, I, for one, have filed a patent for a toothbrush attachment to a cell phone. But that's
the other way around.
I'm filing a patent for a cinnamon flavor for a microphone. No, I mean, one question is, should this spill over in more and in some different way to the teaching we do, undergraduate or graduate? And Malcolm mentioned, I'll say guest lectures in courses, which is certainly something that we could do. But the other question is, do we need a course? Or whether it's a 15-week course or a course in a shorter format, bringing excuse me, different disciplines and maybe different perspectives, whether it's a lecture course or a symposium. But one of the things is that as a faculty member of 33 years, so I'm still learning about how Berkeley works, I don't interact with my colleagues very much. I interact with them through consulting projects or serving on National Academy of Science committees. And I interact with them because I discover my students are taking their courses or consulting with them, and so I learn indirectly that way. But there's very much a sort of stovepipe setting, where as faculty members we sort of function within departments very much. And so it may be that there would be space for this. For 5 years I've failed to act, but I've wanted to propose a graduate group in water, which would function like the graduate group in medieval studies. And let me say this is only one mechanism, so I'm not suggesting it. But the graduate group in medieval studies doesn't admit graduate students. So it doesn't compete with existing graduate programs, but it has a set of courses. So you admit it into some existing program, like art history or English literature or history. But if you take these extra courses and maybe an extra exam, you have, in addition to your graduate degree in whatever, you have, I forget the technical language, but you also have a special certification in medieval studies. And I thought one could do something like that with water, for example, but it doesn't have to be. Well, we would have a small number of courses. I mean, there'd be a menu so that you chose what you wanted to take. But anyhow, whether it's a course or a symposium or a seminar or a something, but the fact is, you and I, George, and Kirk, and Malcolm, have no interaction through the normal functioning of the university, and the interactions we have come really outside the normal functioning, and maybe that is something that should change.
Thank you. Anyone else? Yep.
Hi, I guess I'm approaching things here from a more of a community perspective. I'm not a student here. I've since left the university for several years. But something that I find interesting is, and I only heard about this symposium because I'm on a particular public health listserv. But I would really like to put out there that in terms of education, it's not just the UCs that function as centers of education and learning and dissemination of information and knowledge, but also that there's a very rich community college system just within our boundaries. So it's not just UC Berkeley. There's Merritt College. There's the Berkeley City College, Laney, and as well as other community colleges where there are a lot of young people just as interested in these topics as you are, but who don't quite have the same access to world-class faculty, world-class research that some of you do. So I would put that out there as a suggestion, as a way to get more ideas, as well as to disseminate research and propagate some of these very important topics that we're talking about. And that's the main thing I want to talk about. Number two is there are bottom-up, addressing one of the questions that was raised by a woman over there. There are bottom-up approaches that simultaneously try to address urbanization and climate change that are taking place in. There are certain rainforest projects that are a collaboration between funders in the quote global north, in the so-called developed world, and indigenous people in certain areas, including rainforest areas in Southeast Asia, Brazil, and also some of the island nations in the Pacific. So there are these different collaborations already happening that are potentially sources for tackling several of these problems at once. And it's kind of an untraditional approach, but looking at empowering people at that level and assuming that they actually have a lot of knowledge about their local environment, and that if you can empower them, and give them the resources that they need to reestablish a hold on the local area, then that can reverse some of these processes.
Thank you very much. One last comment, and then we'll turn it over to Kurt.
I guess I'd address the things like global warming and stuff with a very simple question, which is, what has the future ever done for me? And the point is, the reason you have to do these bottom-up explorations and investigations that the previous speaker and lots of others talked about is you have to understand what sucks in their life so that when you're working on a solution with them, it might actually be something they'd want to adopt. And so one movement I think that's very important for Berkeley is to build more ties, to learn what works and doesn't work in other people's lives so that we learn from them and our solutions are actually going to be something they would implement. The point is that the people in Bangladesh that are going to lose their homes are not the main priority of poor people in coal mining parts of China, and it would be unreasonable to expect poor people in China to make that their priority. So we have to think what are their priorities and what solutions can we find that solve their problems and also address global warming. So I think there's an exciting learning agenda for Berkeley, but it's ambitious because it means we have to get out of this very nice room that we've enjoyed spending so long in.
I must say that since David asked the glib question of what has future done for me, I can give a glib answer, which is given my life meaning. And so without the future, there is no meaning. But that is a glib answer, too, if you're talking about real survival needs in somewhere. I counted it up. I've been to 8 climate meetings in the last 2 weeks, not counting this one. So, what they used to say about the British Empire is certainly true. The sun never sets on climate meetings, or climate change meetings. But, one of the things I've learned, I'm usually the health person there or the co-benefits person at these meetings, and one of the things I've learned is what a small fraction of my health colleagues, let's say, health scientist colleagues, researcher colleagues, have actually engaged in the climate change agenda. Now, many of them work on things that are related to climate change, like malaria or diarrhea or schistosomiasis or surveillance for emerging diseases, all of the kinds of things that we see as potential outcomes of climate change. But they don't see themselves in it, and I think it's partly because the way that it has been framed. And this framing has come out of just historically, it's come out of the natural science community, out of the atmospheric science community, out of the IPCC, this framing of mitigation and adaptation. And in fact, the term adaptation is actually I think, rather pernicious in the context of what we're talking about. Because, just to put it kind of over simplistically, if I go to a malaria person and I say, well, aren't you worried about climate change? You might have 1.1 million people dying of malaria in 20 years. And then they sort of look at you, but you say, but I have 1 million people dying of malaria already. That's okay. Climate change may be another risk factor, but it's a small one actually compared to what's affecting, keeping us from solving malaria now. It may change the trajectory a bit, but it's actually framing it as adaptation. Why would I adapt to climate change and nothing else? I'm not happy with the current situation. I don't want no malaria. I don't want to adapt to something that'll keep me at the same amount of malaria. So it's a little oversimplified, but so I've been thinking about reframing it, and in this meeting, I think, provides some input into that. The common themes here have been risk was one of them, and perception, and of course global change in various ways. Bringing the whole population growth issue back on the table, I think, is very important, and the Bixby Center has been central in this globally, and we all need to support this. One aspect of it that is striking, talking to Ndola, that's striking to me is what wasn't even mentioned so far today, and that was the big health benefits of birth spacing. You can actually get rid of 2 of the 10 million premature children dying unnecessarily in the world by spacing births correctly. So this is a huge public health benefit from just giving women the right to control their own birth spacing. It's not population control, it's just giving people the right to make their decisions, the same as rights that all the women in this room have. The other thing is, a way of looking at it is, of course, we have to eventually get to a stabilized population. The world cannot have exponential population in the long run. So when is that going to occur? Is that going to occur in the next 10 years, or is it going to occur in 100 years? Well, helping women have access to contraception makes it happen earlier. And that, of course, makes much less stress on the planet, as well as all the human systems that support us, education and housing and roads and so forth. So it's not a matter, if it's going to happen, it's a matter of helping it happen sooner so that we are all in a better position in the long run. But, so that's 2 issues, the risk issue, the population issue. But when I sit at these meetings, and this one too, I think, the really basic issue, and it's been mentioned in every single group, and we named one of the groups, of course, vulnerability is really the issue. And vulnerability is, of course, has a health meaning, but it has a broader meaning in terms of society, the kind of, urban planning sorts of issues that Jason talks about, the making places safe, or making us less vulnerable in the places where we spend the time. That's a health, but it's beyond that. But vulnerability, the lack of vulnerability, is not a very salubrious phrase. So I was trying to think of it, if you were going to name a program that would bring in the vulnerability idea, but maybe phrase it a bit more positively, and I'm going to propose it here as maybe a name of this course that somebody was proposing, and Michael was proposing we might teach, would be, the right to resilience. Because resilience sort of covers the vulnerability side, but it also covers all these other aspects that aren't exactly, it covers it all the way from you have the right to be vaccinated. You have the right to a health service, a health community that's doing good surveillance and letting you know about it. You have the right to a safe place. You have the right to reproductive services. These are all part of a resilience framework, I would say. I mean, it's just a suggestion. But it seems better than the lack of vulnerability. It's a positive statement. And it's not quite as fuzzy, I don't think, as sustainable. Personally, I think you could actually define resilience pretty well in many different realms. It's very hard to define sustainable, although we can all sign up for the idea. And then one could think of the other side of that coin is that not only the right to resilience is the route to resilience. And that is the part of this, perhaps this meeting we didn't really get into as much as we could have if we'd had more time, is actually what should we do, who should do it, how should we organize to do it, how should we teach for it. So the right to resilience, that's sort of the assessment side of it. What is the pattern of resilience now? And then the route to it would be the interventions, or however you want to phrase it, the political structures, the assessment mechanisms, the funding, the microfinance, the educational systems that would bring us that resilience. So that's my proposal, to summing it up, is the right to resilience and the route to resilience. Thank you.
And finally, to close us, the man who needs in this room no introduction, Dean Steve Shortell. Thank you, Dean.
First of all, let me begin by thanking all the speakers and panelists today. I thought they were absolutely terrific. And let's, thank them now, and we'll thank them later as well. I also really want to thank Eva and Kirk, who in my mind at least were the original germinators of this idea in some of the meetings we had this past year. And Miriam, where's Miriam, who pulled this together? on very short notice, and a number of others as well. And also I want to thank George for his light-handed facilitation and guiding us throughout the day. Great. Just make a few comments, and in particular in terms of, I want to throw out some suggestions and ideas for next steps in terms of the action orientation we'd like to see occur. Graham Fleming said this morning in kicking this off that we have the potential here at Berkeley to really influence events. These are big challenges, as been laid out, but we do have that potential here. The question I have for us is the extent to which we are going to achieve that potential. These problems, as laid out today, are not just economic problems or biological problems or atmospheric problems or social problems or on and on. They are simply major problems that the world faces. And they are going to be a terrific challenge to narrowly define disciplines and boundaries of the academy. This has been alluded to earlier. So these are part of our internal challenge at Berkeley, is how do we step up to address and break down some of these silos as we've done today, okay? But how do we do this on a more continuing kind of basis? And this, I think, is the leadership, special leadership obligation of the Berkeley Alliance for Global Health, as well as other entities on campus as well. So part of what makes this a little bit more doable, I think, is the fact that if we come together, we can begin to, break these down a bit, see the interdependencies as well, and figure out what we can do. I would also add to this, though, that although a lot of the focus today has been on infectious diseases and how climate change and the global economy and a number of other things, and swine flu most recently, are huge issues, to remind ourselves, in particular in the developing world, you have the double jeopardy, and that is the chronic illnesses as well. And just to cite just a few dimensions of that, 60% of all deaths now worldwide are due to chronic illness. 80% of those are in low and middle income countries. If you go out about 10 years, if you're worried about the interdependency of economies and the global crisis and so forth, in China, over the next 10 years, the chronic illnesses alone are going to cost $558 billion. In India, that figure's about $237 billion. In fact, in India last year, about 2.5 million people died from infectious disease, 2 million died from chronic illness. So this is a huge issue that is above and beyond, as much as we worry about the infectious diseases, they do interact with these other factors as well. I think it was Einstein who said something like, every problem ought to be addressed in as simple a way as possible, but no simpler than the inherent complexity of the problem. He said it much more elegantly than that, but I think that was the basic message. And so again, today you go away, I certainly go away almost overwhelmed with some of the complexity of this. But I think the way in which we can get a sense of making some progress here at Berkeley, working with others, is by coming together in forums like this and breaking down some of the silos. So let me offer 7 or 8 concrete suggestions and stimulate some of your thinking as well. First of all, I think we have to figure out what is our comparative advantage. What is our comparative advantage here at Berkeley? And that's very difficult for us to do because of the breadth and depth of almost across-the-board excellence we have here. It's actually much easier for other universities and colleges who don't have the strengths that we have. Their strengths kind of stand out. They can easily discern that and say, this is our comparative advantage, we'll run with it. We have a wealth of riches here that sometimes almost, say we can do everything all at once all the time, and I think we don't have as much impact as we could have if we try to really figure out in this space of global change, what is our comparative advantage? Where are we going to focus? Because we can't do everything. And we also need some degree of realistic humility, which is to say there are a lot of other universities attacking these issues, a lot of other not-for-profits, et cetera. So we have to pick our partners, I think, very carefully as well, and we should pick them in areas where we're not quite as strong so they augment our strengths and not duplicate our strengths. So this is a question that I think we have to give more attention to. Concretely, I would suggest that the Global Change Initiative, or whatever we might call it here, that we break down into work groups. We break down into facilitated work groups over the coming year, begin to sharpen some of the issues here today, begin to sharpen the kinds of interventions that we might design, begin to sharpen what's going to go into these white papers, and sharpen the proposals on the grant support we're going to need. And part of that is figuring out our comparative advantage as well. Most of the interventions that I'm familiar with, and I do not consider myself a global health expert, but I do know something about designing interventions and evaluation of research and so on, are not single things. They're packages, they're bundles. It's not a matter of a simple vaccine. It's a matter, can you get access to it? It's a matter of the economic system, et cetera, et cetera. So I think part of this is we need to give a lot of attention to this kind of bundling of interventions. And secondly, and I think Jason's comments underscored it, the study of context, the study of context. In a simple-minded way, kind of being glib here at the end, you have content and context. Content is what can be done, what's the new drug, the new cure, the new technology, et cetera. Context is the messy world, the settings in which those things have to be implemented. Okay, it's not the academic medical center, randomized controlled trial, and then it gets out there in the messy everyday life of where people get their healthcare services, and in this case, all the messy stuff that goes on in developing countries. So maybe Berkeley's comparative advantage is really studying the interaction of content and context. Third, I would direct these groups to identify the big levers for change and where you're really going to get some payoff. The 2-for-1 solutions or the co-benefits, for example, okay? Trying to figure out what those big levers really are, because there's lots of other things that could be done. Fourth, I think it'd be terrific to give some attention to developing a global change performance system, a global change metrics. How are we going to measure our progress here if a year from now we have another symposium, which I hope we do, and I hope it goes above and beyond as much as what we did here today. A lot of it was describing the problem, which is very important to do, honoring the problem, so to speak. But next year's symposium, I hope we're going to be talking about what are some of the interventions out there that maybe we initiated. It's too short a time frame, of course, in a year to say much, but there's a lot of other things already going out there, and we can bring to bear some of the emerging evidence on what impact we're going to have. So I'm not suggesting we reinvent the wheel, because I realize there's a lot of metrics already out there and a lot of folks already thinking about this stuff. But let's build on that, let's refine it, and let's say, how are we going to measure our global change efforts here at Berkeley in terms of moving the ticker on some of these things that we're concerned about? So I would pose that as a charge to the group. Next year's symposium, certainly I would hope this would be an annual event where we can address some of those issues. And the two final things I would say is the need for the public-private partnerships, choosing our partners carefully and wisely, including right here in our own backyard, the last comment about community colleges and other universities in the area, but obviously the rich intellectual capital we have here in the Bay Area, the economic capital here in the Bay Area, as well as our partners overseas. And I think this is an area that deserves a lot of careful thought. And finally, raising the resources. I realize that's partly my job. I share it with all of you. This is at the top of our fundraising list for the school on behalf of the campus, for the Global Health Alliance, the Berkeley Alliance for Global Health, both the Center for Global Public Health and the Center for Emerging and Neglected Diseases. But clearly, in addition to the proposal writing, we need to capture the imagination and the legacy that the philanthropists here in the Bay Area want to leave. We need to figure out a way to get this on their philanthropic agenda, and I welcome your thoughts on that. So in closing, again, I want to thank everybody for doing this, thank Kirk, and turn it back over to Kirk.
So it's time to close up, but I just want to provide some more thanks here, of course, to the Vice Chancellor and to Steve for opening and closing us today, and our keynote speakers, Trevor, Alex, and Steve. And of course, the sponsors or hosts of this, some of which have been mentioned: Berkeley Alliance for Global Health, the Center for Global Public Health, the Center for Emerging and Neglected Diseases, the Bixby Center for Population Health, and the Berkeley Water Center, and Global Metropolitan Studies on campus. Much appreciate their support for this, and look forward to working together with them, which provide, probably some of you hadn't heard of these organizations. They're all doing some interesting things directly related to the topics here. And then, of course, thanks again to George, who did so much of the work in organizing this and organizing us, who were involved in it. And let's give George a hand, actually. And then unsung, of course, is Miriam Rafiq. Stand up, Miriam, who actually did all the organizing. Yes. So, thank you very much, and we'll see you next year, I hope.